An NGS testing with a short turnaround time is key because most of the drug we have access to can be given upfront. In most of the cases, we have the results upfront, but in a third of the lung cancer patients, we know that we will not have sufficient tumor tissue to have the whole profile. In these cases, I highly recommend a new biopsy, in particular in patients that are light smokers, less than 15 pack years, or never smoker. In some cases, you cannot wait. The disease evolves too rapidly and you have to start a treatment, then you have to start a platinum-based chemotherapy, and this is not a mistake. What you should do in these cases is run in parallel the NGS testing, and if you have no sufficient tissue, schedule a new biopsy while the patient starts his platinum-based chemotherapy. We know that most of these drugs works whatever the patient receives or not a platinum-based chemotherapy, but the few data that we have suggest that in platinum-naive patients, this drug could be a bit more active.
In the past, I wouldn't have necessarily said that everybody should have widespread NGS and fusion testing up front, because in the case of differentiated thyroid cancer, both of the agents we use regardless of whether or not there's a mutation. The same is true in medullary thyroid cancer, where both vandetanib and cabozantinib work in patients both with and without RET mutations. So I often would start patients on one of these first-line agents and then go ahead and get the testing at a later point. However, now fusion testing, particularly in differentiated thyroid cancer, can identify both RET fusion and TRK fusion genes. And those are ones that we now have new agents for that can target these genes specifically and with very little toxicity because they're so specific for either RET or TRK genes by themselves that the overlapping toxicities in other pathways is minimal. That can be such an improvement in people's quality of life. It can be a game changer. So if the patient happens to have one of those with differentiated thyroid cancer, it's not always that common, but if they do, it would possibly make me think about starting a patient on a RET inhibitor or a TRK inhibitor prior to being on the other agents that we would recommend for toxicity reasons. The same is actually true in medullary thyroid cancer. Now that we have RET really specific targeted agents with the RET mutation, with the RET inhibitors, now we would actually think about trying that first before the cabozantinib and vandetanib, because the side effect profile is so much more improved when you target RET alone instead of targeting RET along with other targets that cause toxicity. A lot of patients who come to me have already had testing for germline mutations in RET. And that's because people with medullary thyroid cancer have such a high likelihood, up to 20%, 25% chance of having a familial RET mutation. However, there are some patients who come to me who've not had the hereditary testing. And so I will test for this, usually the somatic test first. And the reason for that is that it will give me both the hereditary and the non-hereditary ones. It will answer the question I need to know for that patient, which is, do they have a RET mutation? If the answer is yes, which it is in 65% of the time, in those patients, I will then reflexively go back and do the hereditary testing. So it doesn't necessarily mean that you have to do one order or the other. If they've had hereditary testing, though, you absolutely need to check for sporadic mutations, because you can have another 25% of patients that have that mutation. So it's really, really important, especially in medullary thyroid cancer, that patients get checked for both.